Welcome to Part 5 of our Explainer series. We're diving right back in, and this explainer is based on Post-Concussion Dizziness, a vestibular physician's deep review of mechanism, diagnosis, and management, published by Australian Dizziness Clinics.
Today, we're zeroing in on management, specifically subtype-directed treatment. When we're dealing with post-concussion dizziness, treatment absolutely has to follow the specific subtype. Because these presentations are just so incredibly complex, getting a patient back to their baseline almost always takes a really well-coordinated combination of modalities.
I want to start with a core principle that really sets the stage for everything we do. Ready? Reposition what is mechanical, retrain what is central, and treat the functional and migrainous layers. Since post-concussion dizziness is highly heterogeneous, we are never going to find some magic silver bullet that cures everyone. We literally have to methodically address every single layer of the injury. To navigate all these complex, multidisciplinary strategies, we'll follow a pathway and pillar structure today. First, peripheral vestibular management. Second, central rehabilitation. Third, chronic phase pharmacotherapy. And finally, review and escalation protocols. All right, let's jump straight into Part 1, peripheral vestibular management. This is the mechanical layer. So traumatic BPPV is a completely different beast from your standard idiopathic variety. Sure, it responds to standard repositioning maneuvers like the Epley or Gufani. But clinically, you've got to anticipate a really turbulent course. Be ready for multi-canal disease that's going to need sequential treatments. Keep a very close eye out for canal conversion during repositioning, and crucially, expect a much higher burden of residual dizziness and oscillopsia. That's just the reality of the accompanying central sensitization.
Moving beyond BPP, we also run into labyrinthine concussions and paralimb fistulas. Now, for a labyrinthine concussion, early, directed vestibular rehab is absolutely key. We're talking gaze stabilization exercises, like VOR ×1 and ×2, plus habituation and adaptation exercises to really accelerate that cerebellar compensation. But if you even suspect a paralimb fistula, the game plan flips completely. Initial management means strict rest. And if that fistula still doesn't resolve, well, you have to be ready to escalate to surgical exploration.
Let's move on to Part 2, central rehabilitation, which is all about metabolic retraining.
Here is a number you really need to remember: 80 to 85%. That is your target symptom exacerbation threshold heart rate on the Buffalo Concussion Treadmill Test. It's literally the cornerstone of central rehab. The clinical evidence tells us that carefully and consistently training patients at this specific subthreshold level gives us the absolute fastest recovery rates.
But hey, aerobic exercise is just one piece of this giant puzzle. If we map out the 5 concussion trajectories, it's clear that while the vestibular component might be the loudest, secondary contributors are almost always lurking in the background. So what does that mean? It means subthreshold exercise has to be paired with targeted oculomotor VRT, think smooth pursuit training, cervical physiotherapy, and neuropsychology. You really have to hit all those concurrent central contributors at the exact same time.
Okay, I need to give a very stark clinical warning here. Vestibular suppressants actively impede cerebellar-mediated VOR compensation. You must strictly restrict their use to the first 24 to 72 hours post-injury, and only for acute relief. Seriously, stretching their use beyond that short window will just delay your patient's functional recovery.
All right, moving right along to Part 3, chronic phase pharmacotherapy. This is where we tackle the functional and migrainous layers.
Chronic care really requires dual targets. Take persistent postural perceptual dizziness, or PPP. For that, you need a powerful triad: graded VRT, cognitive behavioral therapy, and an SSRI or SNRI started at a very, very low dose. On the flip side, post-traumatic vestibular migraine leans heavily on lifestyle measures and preventative pharmacotherapy. These conditions frequently superimpose right on top of structural injuries, so we have to treat them concurrently with peripheral therapies if we want to break that symptom cycle.
Let's look at the evidence-based guidelines for a second. For PPPD, agents like sertraline directly target serotonin receptors in the vestibular pathways. The golden rule here is start low, increase slowly, and keep them on it for at least 3 to 6 months. Now for vestibular migraines, we've got level A evidence backing propranolol and topiramate. And what's really exciting is the growing, specific evidence for the CGRP pathway. We're actually seeing injectable monoclonal antibodies stepping up as a really solid second-line defense.
Which brings us to Part 4, review and escalation, or how we track recovery. When it comes to post-concussion care,
timing is everything. After the acute injury on day 0, we want to kick off that sub-symptom aerobic exercise nice and early, right around days 2 to 7. But the true make-or-break checkpoint, that hits at weeks 4 to 6. At this stage, you cannot just rely on subjective symptom reports. You've got to measure progress objectively against validated tools like the VOMS, the vestibular/oculomotor screening, and the dizziness handicap inventory.
Now, if you hit that critical 4 to 6 week mark and your patient's recovery has plateaued or worse, their symptoms are flaring up, you have to escalate to a multidisciplinary team. This is exactly when you pull in neuro-otology, psychology, or surgical consults to dig into those refractory causes. You're basically hunting for the roadblocks: missed fistulas, untreated vestibular migraines, or maybe psychological amplification that's stalling out the whole recovery.
So let's distill all of this down into a few high-yield clinical pearls. Number 1, always reposition peripheral disease, but fully expect multi-canal involvement and residual dizziness. Number 2, sub-symptom-threshold aerobic exercise is your absolute cornerstone for central rehab. Number 3, for chronic layers like PPPD and post-traumatic migraine, you need a combined arms approach: VRT, CBT, and targeted pharmacology. And finally, please strictly restrict those vestibular suppressants to the first 24 to 72 hours. Do not let them delay your patient's central compensation.
But all of this brings up a rather complex reality, right? What happens when, despite giving them your absolute best subtype-directed treatments, a patient's post-concussion dizziness persists into refractory disease? Or, even more daunting, what happens when these cases end up in the courtroom? Well, in Part 6 of this Explainer series, we are going to explore prognosis, refractory disease, special populations, and the whole medical-legal dimension.
This has been an Australian Dizziness Clinics Vestibular Physician Review. Visit AustralianDizzinessClinics.com for the full literature review and clinical cheat sheet.